Hi, I'm Howard Jack West, and I'm a medical oncologist with a focus on thoracic oncology. I'm an associate clinical professor at the City of Hope Comprehensive Cancer Center in the Los Angeles area. For patients who have pre-existing interstitial lung disease, I would say that one key point is that we don't have good data about the best approach. These patients were really not eligible to be enrolled on the clinical trials, and that means that it is appropriate to individualize based on the patient's extent of disease and how limiting that is, and to incorporate judgment and a patient's own preferences. I would say that the clearest concern I would have would be around pursuing concurrent chemoradiation and consolidation durvalumab along the lines of the Pacific trial. I don't think that would be feasible for patients with anything but the mildest version of interstitial lung disease, and would not pursue that. Though I think if someone had a limited amount of radiation that would need to be administered in terms of the size of the radiation field because of the location and size of the tumor, I would certainly consider whether it's feasible to do concurrent chemoradiation. Otherwise, I would certainly include the best estimates from a pulmonologist involved in the patient's care and the radiation oncologist about the ability of a patient to tolerate a concurrent approach or even definitive radiation, potentially administered sequentially if needed, and possibly consider trying to shrink that radiation field by starting with induction chemotherapy and then rolling into either sequential radiation or concurrent chemoradiation after a couple of cycles of initial chemotherapy. But this is a setting where there are really no good data, no rules here, and we're left with our own best judgment, as well as an important consideration of how severe the cancer is relative to and the pace of disease relative to the interstitial lung disease, and whether that is going to be profoundly limiting in terms of ability to administer treatment, as well as a patient's quality of life and length of life. So these patients need an individualized approach, and I would just be most wary about administering immunotherapy to somebody with pre-existing ILD. But I hope that we get more information on this in the coming years, because certainly we are getting a clearer sense of what's optimal, at least for patients who have a good performance status and without limiting comorbidities. But there are a lot of patients out there in the world who are not these idealized patients, who still need to get treatment as best we can.